On behalf of the BC Health Coalition Steering Committee, I'd like to welcome everyone to today's Seniors Care Accountability Assembly. The BC Health Coalition acknowledges we are based on the unceded and traditional territories of the Coast Salish nations of Musqueam, Tsleil-Waututh, and Squamish. We also acknowledge the many territories and lands across Turtle Island that you are joining us from. We are honored to be here as guests on this land that Indigenous peoples have cared for and continue to care for. We invite you to take a moment to think about where you presently live and honor the people of the land. Think about your relation to the place you live, work, and interact. This is our inquiry to honor the past and present and to stay connected to decolonization practices. Thank you. At the BC Health Coalition, our role is to bring together a broad cross-section of civil society to fight for public solutions to healthcare issues. We are a democratic, inclusive, and consensus-based community of individuals and organizations dedicated to advocating for evidence-based solutions, defending our public healthcare system from for-profit interests, and building a constituency to support and demand change where BC residents need it the most. We have a strong history of defending our public healthcare laws in court and driving positive change to our healthcare system through campaigns across the province. During the pandemic, the BC NDP made strong commitments to seniors' care in their previous election platform and reiterated these in Minister Dix's mandate. We saw evidence that our government is able to take bold action and invest significantly when it has the political will to do so. We know that there is a strong constituency across this province that is ready to support strong reforms across seniors' care. The work of the Better Care for Seniors campaign is to hold the Ministry of Health accountable to its mandate from our government and ensure a seniors care system that is accountable to the people of this province. You'll learn much more about who's in our coalition at our roll call in about 30 minutes, so hang tight. But for now, I'd like to introduce you to the moderator of today's event, Margot Beauchamp from the Jewish Seniors Alliance.
Hello, everybody. Good evening. Thank you so much for being here. I'm honored to be moderating this important event, and I'd like to thank the BC Health Coalition and everyone involved in the extraordinary planning that's taken place. I'm going to start with an overview of an issue analysis about seniors' care in BC. Like many of you, we've known for a long time that there's a need for real systemic reform in our seniors' care system. Long before the pandemic hit, seniors organizations, community groups, healthcare workers, researchers, and advocates had already spent years calling attention to the gaps in our seniors' care system. Actually, it was less of a public health care system and more of a patchwork of services that may or may not be available when individuals really need them. The downstream approach we have means care often comes in too late when the needs are complex and interventions become very expensive. As many have pointed out, the prevalence of ageism meant general apathy about these well-established issues. The approach is too often seems to be to minimize costs, keep seniors out of sight and out of mind. We believe that a human rights framework would mean that our public system would fully fund an integrated continuum of care. From community programs in primary care to home care and home support to assisted living and residential long-term care, people should be able to age with the right supports at the right time. It is a scarcity mentality that pits the many forms of seniors' care against each other. Austerity governments have trained us to think in either or terms. They can either invest in home care or long-term care, they say, but not both. People can either age in place or in an institutional model of care. The reality is that it's not either or, but both and. We know that people are nearly unanimous in their preference to age at home. We know that there is a strong interest in exploring new models that offer more supports than the home environment, while also are less institutionalized than residential care. We also know that as our population ages, the complexity of care needs for many increases. and we'll still need to grow our capacity to offer 24/7 safe and high quality environments to meet this growing need. We're here together to stand in solidarity against this either or thinking. What if we could age in place as long as possible and not need to be afraid of what would happen to us if we needed to go into residential care? A human rights approach also means that we do not allow corporations to extract profits from seniors' care. It's an austerity mentality that tells us that we can only afford to take care of our people if we incentivize the private sector to do it for us. When we agree to this, we say that seniors are only as valuable to us as the profits that can be generated for corporations. A human rights approach centers people care and good jobs and sends a clear message that investor profit does not belong in our system of care. A paradigm shift and full system reform will be a lot of work, and we're going to need a strong power base to get there. We're launching this campaign with a specific focus on a few key changes that our provincial government has already made. Commitment towards mainly accountability in long-term care and expansion of home care. Thank you. I will now take some time to do an overview of the agenda. We'll provide an opening event overview and a framing of the issue, which we have just done. I'll be welcoming special guests. We'll take time to do a roll call. There will be a presentation of long-term care evidence based on research, the Ministry of Health mandate on long-term care progress report, and we'll hear about long-term care stories and question and answer. There will be a presentation of home support evidence, Ministry of Health mandate on long-term care progress report, home support stories, question and answer, and a wrap-up. So to begin this evening, or this afternoon, it'll soon be evening, I'd like to introduce Pat Armstrong. Pat is a national expert on long-term care. She's a distinguished research professor in sociology and fellow of the Royal Society of Canada. She held a Canada Health Services Research Foundation Canadian Institute of Health Research Chair in Health Services. Pat, welcome. Thank you so much for being here. And if you would like, you have 8 minutes to present your research on long-term care. Thank you. Oh, Pat, you're muted. Pat, you are muted. If you want to unmute yourself.
It wasn't.
There you go. Thank you.
My apologies. It wasn't working. I won't bore you with the 25 years of research, but I did want to start and thank you very much for that introduction and for all of those people who are doing so much important work in terms of seniors care. Like the 1957 Federal Hospital Insurance and Diagnostic Services Act, the Health Canada Act covers hospitals that provide acute, rehab, or chronic care and requires that all medically necessary services, including meals, accommodation, tests, drugs, and equipment, be provided without charge in order for provinces and territories to get the federal money. Nursing homes are excluded from the Act, but at the time, people with complex care needs were in the hospital, and the federal funding encouraged this. During the same period, provinces like BC expanded welfare state programs, including building nursing homes and funding not-for-profit and private ones, most of which were small. But these public homes were mainly thought of as old folks' homes because that's in quotes, by the way, because residents did not have complicated mental or medical needs. Nevertheless, there were fees for meals, accommodation, and other services. When I first started studying long-term care, no one had oxygen tanks, catheters, feeding tubes, or any other complex treatment. However, as federal government money declined and the enforcement of federal conditions for funding relaxed, and as more people survived with complex care needs, hospitals were more narrowly defined and more care was shifted to nursing homes where fees could be charged. Care needs increased, especially as the number of spaces failed to keep up with demand. but neither staffing numbers nor staff training kept up with these changing care needs. At the same time, and to varying degrees, governments across Canada looked increasingly to the private for-profit corporate sector for service delivery and for managerial models from that sector, while creating conditions that supported corporate entry. It was assumed that competition for customers in the for-profit sector means that quality improves to attract those customers at the same time as the search for profit means efficiency in work organization and in the use of other resources. But when supply does not meet demand, as is the case here, there is little, if any, competition for customers. Moreover, the primary expense in nursing homes is staff, and efficiency mainly means fewer and cheaper staff, often hired on a casual and part-time basis to ensure the lowest possible numbers and the lowest possible pay and benefits, which too often means the lowest possible care. Caring for people is not the same as making cars. And the argument that corporations have the capital to invest ignores the fact that governments have lower borrowing costs and end up paying more in the long term for corporate homes. Meanwhile, corporations are attracted, as we just heard, by the gold to be made from the golden years. It's important to remember that for-profit homes must have profit as their objective and must report to their shareholders. In BC today, 37% of the homes are for-profit, 35% public, and 29% not-for-profit. The impact of all this is visible in nursing homes, even the public and not-for-profit ones. When our research team studied a not-for-profit home in BC, we saw this most visibly in relation to food services that were contracted out to a for-profit firm. I vividly remember observing in a dining room at 7 a.m., staff wheeled in a fully dressed man to his designated place, leaving a cooking show on TV as he waited an hour for the contracted company to deliver and serve breakfast. The food was wheeled in on massive rattling carts, stacked with trays that identified residents by number. Except for some drinks, the trays included the entire meal, both hot and cold items. The corporate employees delivering and serving the food did not know the residents or the home's employees. A large sign said, "Do not speak to the servers." Trays were whisked away at precisely 9 o'clock. Many of the trays had significant amounts of food uneaten, not surprisingly, given that it was often all the same color, had been prepared long before and off-site, and full trays often overwhelmed seniors' appetites. I should say, we tasted the food in all the homes we studied. No sacrifice is too great for research. Residents had limited, if any, choice about when, what, and with whom to eat or even talk to. No eating in your pajamas, no leisurely wake up, no arriving at 9, no chat with the dietary staff. I could go on. Staff had to rush to get everyone dressed and in the dining room for 8, and then rush to help them eat so they are done by 9, too often promoting stress for everyone and even violence. Staff don't know the private company employees, making it difficult to provide mutual support and corporate care. Some employees who help with eating are, I should say cooperative care. Some employees who help with eating are hired only for meal times, leaving them with little pay and little union protection or any other worker rights. Some others employed by the home were also casual or part-time, hired to limit staffing levels as much as possible. Teamwork is undermined, and full-time staff often must take time to teach these casual and part-time workers who don't know the home or the residents. Those employed by the food company faced even worse conditions. It need not be that way, as we saw in another not-for-profit home in BC we studied. It had a food-first strategy and was committed to hiring their own staff for dietary, housekeeping, and maintenance services, as well as for direct care. The result was low staff turnover, smooth teamwork in cooking and serving food, and procurement from local sources, with food adjusted to different populations within the home. Dietary staff knew the residents and other workers and reduced waste by responding to individual preferences in amounts and choices. Staff took pride in the mixture and texture of their food choices. Residents could sleep in until 10 and still have breakfast. They were not rushed through the meal, even when they ate at 10. In sum, the conditions of work are the conditions of care. We have years of evidence, as we just heard, to show that more staff training, more full-time and permanent part-time jobs, and better working conditions are a necessary but not sufficient condition for addressing the well-known issues in long-term care. We also know that for-profit homes have a pattern of lower staffing levels, even though they receive the same public funding as other homes, evidence produced in specific numbers by the Office of the Seniors Advocate.
Pat, I'm very sorry to interrupt. You have 1 minute.
Okay, so in the wake of nursing home scandals, nursing home scandals, we saw that the most common response was more regulations, but those regulations focused on regulating workers and on workers producing more documents, rather than on the larger structural issues that create the conditions for care, which means regulating owners and managers. There are 3 obvious regulations. Let me see if I can briefly list them in my remaining less than a minute. First of all, it's staffing, and we have lots of evidence how they should be a lot higher than the 3.6 under regulations in BC, but we don't even know enough about what staff are available. Obamacare, and I don't very often look to the States, requires each facility to report on the number of nurse and other professional staff in the home to the Centers of Medicaid and Medicare. And the reporting has to be done online on a quarterly basis, providing the data for every single day so we know who does what work when and in what job categories. And enforcement is specified in the legislation. We need to require the same kind of data for all staff and then use it to ensure those minimums are met. Second, numbers are not enough. Staff.
Pat, I'm very, very sorry, but we're a minute over.
Okay.
I apologize. Right. Such a tight agenda. I feel very badly, but
thank you.
I'm so sorry. We need like 6 hours, not 1. Thank you so much. That was fascinating, and thank you so much. I'd now like to move on to introducing Isabel McKenzie. On March 19th, 2014, the government of British Columbia announced the appointment of Isabel McKenzie as Canada's first seniors advocate. Isabel McKenzie has over 20 years experience working with seniors in home care, licensed care, community services, and volunteer services. And Isabel, you have 7 minutes. I know that's nothing, but I'll give you a flag at 1 minute. So go ahead.
Okay, thank you very much. Thank you for organizing this. I'm going to talk a little bit about home support. Just briefly, most of you probably know what it is, but home support is the program. It's not nursing care. It is to help people remain independent and living in their homes. So it is about somebody coming in once a day, a couple of times a day, a couple of times a week to help people maybe get up, get dressed, make sure they're taking their medications, their meals, etc. Home nursing care is different, where nurses will come in and do wound care or attend to you post-discharge from the hospital. I'm speaking about actual home support that most people, once they're on the home support program, they're going to require home support for the entirety of their life living at home. So just in terms of British Columbia, all provinces have a public home support system, meaning that the government through various means will provide home support services to people who require it. As with long-term care, as Pat has identified, it isn't under the Canada Health Act. There's no requirement that it be provided free of charge. Some governments don't charge for it. Here in British Columbia, we do charge people for their publicly subsidized home support, and we actually charge the most of any province in British Columbia, and I'll talk more about that in a minute. In sort of the macro level, there are about 45,000 home support clients in any given year in British Columbia. So some people will be a home support client, maybe just to support a discharge from the hospital. They'll be included in that number. About half of that number are what we call long-term home support people, people who are getting it regularly on an ongoing basis. We provide in BC about 12 million hours a year of home support, or 261 hours per person per year. So again, that per person per year number doesn't sound like much, But you've got in the mix some people who are only getting it for a few days after they get home from the hospital, along with people who get it throughout the rest of their lifespan. What is interesting in British Columbia is that about half of the people receiving home supports in this province have something called a MAPLE score 4 or 5. And what that means is that they actually qualify for long-term care services at that point, but we are providing home support services for them. What's interesting is, despite the fact that half our home support clients have this MAPLE 4 or 5 measure of acuity, only a third of them are getting more than an hour of care a day, and only 11% get 3 or more hours of care a day. So think about, you're in long-term care, 3.36 hours of care on average. Here's people, half of them would qualify for long-term care, but only 1 out of 10 are getting 3 or more hours of care a day. So home support can be a lifeline for many people. It is what is keeping them out of long-term care, and it's working well for them. That describes probably maybe about a third of our home support clients. But for the other 2/3, and more importantly, for the others who aren't getting home support, the program isn't working at all for them. And what are some of the reasons? First of all is the cost. So to put it in perspective, in British Columbia, we have what we call a daily rate that we charge you, and it's based on your income. If you're in the lowest incomes of seniors, you're on the guaranteed income supplement, we don't apply a daily rate. That's about a third of seniors in British Columbia, although it's 2/3 of our home support clients. If your income is $28,000 a year, we're going to charge you $8,800 a year for that daily visit. So cost is part of it. Restrictions of services is another part of it, and the ability to attract the staff that is necessary. So, you know, Pat has talked about the challenges in long-term care around staffing and how that interweaves with the incentive models and the private sector. In home support in British Columbia now, all of the public home support is delivered by employees of health authorities. And the wages that they're paid, the hourly wage rate, is not the biggest part of the problem. It's the number of hours they get. 70% of the home support workforce is casual. And some of the things we could do to fix home support in terms of better supporting people at home would also make it more attractive to become to the workforce, to become a home support worker. And I think we need to look at that as we move forward. We need to look at in the basket of services that we offer. For example, we don't provide housekeeping any longer in home support. When I started almost 30 years ago, we did provide housekeeping services. Because we don't provide housekeeping services, there's really nothing to fill up the afternoon schedules for many of the community health workers, which is why they don't have full-time jobs. If we brought housekeeping back in, we would be providing that service, and we would be providing the ability to create more full-time jobs and attract more people as community health workers. We've also devolved around meal preparation. In the old days, we used to take what was in the refrigerator, figure out how to make a meal. Now we've moved to, we will only heat up prepared meals as our meal service. So you can see a continual theme here where the service has been eroding over the past number of years. And I think
Isabel, I'm sorry, I have to give you your 1 minute.
1 minute. So the 1 minute. So here's the takeaways. 2/3 of people entering long-term care had no home support 90 days prior to their admission to long-term care. That's a failure of the system. If we look at whether it's the number of clients, the number of hours, the hours per client, relative to the target population in BC over the last 5 years, everything has decreased. And we really need to turn that around if we're going to be able to support people to live at home for as long as they want. And so that only those that most need to be in long-term care and have no alternative options find themselves in long-term care, which also requires some improvements. And there's my timer telling me I'm finished. So
Okay,
that I'll wrap up.
thank you. I'm glad you did that and not me. It's horrible asking somebody to finish up because we all are just desperate to hear this information. Thank you so much. And now we'll go back to Mazda for a membership presentation call to action. Thanks, Mazda.
Hi, folks. So we'll be joined in a few minutes by the Minister of Health, Adrian Dix, and Parliamentary Secretary Mabel Elmore, who will be listening to our coalition's roll call and stories from workers, seniors, and family members. While we only have time for a few folks to engage with the minister, we know that there are many workers, folks from seniors organizations, retiree associations, seniors programs out in community, neighborhood houses, peer volunteers, nonprofits, family caregivers, and many others who also have their own stories and questions for the minister. So if this describes you, we'd like you to follow the link that my colleagues are putting in the chat and submit to us your questions and stories. So as a follow-up with Minister Dix, we're going to take all of your submissions, put them together in a document and send them to the minister's office. And, you know, we're doing this because we know that your stories are going to continue forming the backbone of this campaign. And our plan is to keep engaging you, tell your stories, and show how important it is for the government to make these necessary changes. So we're going to be keeping track of the government's progress and updating you. So please do get in touch with us. And with that, we're going to take a quick break, just a couple of minutes, and come back when we see folks arrive with the minister as well. So just a couple of quick minutes as we get set up here. Thank you.
Thank you very much. And I'm very, very pleased to introduce our special guests that we have here this evening. I'd like to introduce the Minister of Health, Adrian Dix, and Parliamentary Secretary for Senior Services and Long-Term Care, Mabel Elmore. We would like to start with recognizing all the work that has been done so far by the province in BC. We're appreciative of everything that has been done. I'll take a few minutes to review it. We want to thank you for joining us today, Minister Dix and Mabel Elmore. PS Elmore, we wanted to acknowledge the effort made to improve seniors' care. Over the past few years, the Ministry of Health, under the current government, have made changes that have benefited seniors' care through efforts to increase staffing in seniors' care and through efforts to improve the conditions of work for these staff. The implementation of the Health Career Access Program, HCAP, offering paid education and wages while training, has already started to increase the number of workers in long-term care, assisted living, and in community settings, including home care. Leveling the wages of care aides to public sector wages has meant an increase of up to $8 an hour for long-term care staff. This policy change has ensured that workers in all facilities, regardless of ownership type, make the same wage and has effectively addressed wage disparity in the sector. Bringing home care support workers under government employment in 2019 was another significant step in addressing the insecure nature of contract-based work for private companies and will better support seniors. The gains made in senior care in BC have supported both seniors and workers in the long-term care and home support sectors. Despite these gains, there is still much to do, and we welcome the opportunity to discuss some of the areas in seniors' care that must be addressed and improved upon. And on that note, Minister Dix, if you'd like to take just a minute to introduce yourself.
I would, and certainly I appreciate you highlighting some of the changes that have been made. I think they're profoundly significant in the history of BC. And I think people who have been active in the BC Health Coalition, who have been with us on this road and advocating for those changes, should be justifiably proud of them. The changes, just the ones you talked about, we're talking about over $1 billion. We're talking about massive change in the lives of seniors and of healthcare workers, people providing care both in the community and of course, in long-term care and assisted living. And I would say that I think we have to acknowledge as well that these massive changes, which have really all been consistent with what the BC Health Coalition has advocated and what I advocated and others advocated before the 2017 election have had an enormous difference and are contested and have to be continually recognized, I think, and celebrated both by the Health Coalition and ourselves. And just talk about one person maybe before I go, just because that's what we do.
Okay,
The average,
thank you, Minister
the
Dix.
average person.
Sorry to interrupt, but we just wanted a 1-minute introduction. There's going to be many, many opportunities for you to talk about the issues.
There's going to be an opportunity for us to lay out the issues at this meeting.
There is. We're just, it's a very, very tight schedule. And believe me, there will be opportunities, but we were asking for 1 minute kind of quick intro. And now we'll hear.
So just to be understand, you don't want me to, you're not going to allow me to speak any further. You just want to,
no,
to continue on. Okay.
I'm trying
I
to
just
follow
want to be clear.
Yeah.
Just want to be clear.
It was
okay.
a 1 minute introduction. And now Mabel Elmore is with us, Parliamentary Secretary. And Mabel, if you could take a minute to just do a quick introduction. Thank you.
Thank you. Appreciate the opportunity to join the forum. I know the focus is better care for seniors. Following on your remarks and also the ministers in terms of, as the Parliamentary Secretary for Senior Services and Long-Term Care, my mandate from Premier John Horgan includes working closely with Health Minister Adrian Dixon, carrying out his duties, including delivery of better care to British Columbians and seniors. Adrian has laid out, the ministers laid out, we've been committed to improving wages and benefits, working conditions, job security and stability for healthcare workers that patients count on daily, and continuing to build our public healthcare system. And I want to close, I know my time's leading out, but just in terms of the influenza campaign, to encourage everyone to protect themselves, their loved ones, their communities. And we have this fall a very robust influenza vaccine program. All seniors 65 and older can get an enhanced influenza vaccine.
Okay, thank you so much. That's wonderful to know. And on that note, we'll move on. And Minister Dix, I'm just going to read your mandate in terms of accountability for private for-profit long-term care operators. I'll just read the I'll read the mandate and then you.
Sorry, Margot, sorry to interrupt. We do have the roll call.
Oops, I am sorry.
Yes.
Backtracking. Right, Mazda is going to lead us in a roll call, and then I'll be back after that. Thanks.
Hi, everyone. Just really quick, I want to thank the almost 400 people who are here, 400 attendees. Thank you so much. We're now going to take a few minutes for our organizational roll call. So as a coalition, we have both individual and organizational members. The organizations that make up our base bring strength and credibility to our campaigns and broaden our reach in the province. As you'll be hearing from some of our storytellers and members, just know that they represent a fraction of the many thousands of seniors, families, and workers that all the organizations who are here today represent. To give you a sense of the organizations and members behind this accountability assembly, we want to do a roll call to show you how many people we collectively represent. If your organization is not on our roll call list, feel free to use the chat to introduce yourself and your organization during this time. Our organizational representatives have already been contacted and know what to do, but I'll go over a few things just in case. There will be several slides on the screen with a list of organizations who have registered. We'll invite representatives to simply follow down the list and take turns. This means you have to pay attention to who goes before your organization too. There's a simple script on the top right corner of the slide. When it's your turn, you'll be able to unmute yourself. Please state the full name of yourself and your organization and the number of members you represent if applicable. We're asking you to leave your introduction at that because we're very limited on time. So no explanation of your job titles, the geographical locations of your organization, or the various organizational structures that you do your amazing work in. With advance apologies, we will mute you and keep going if we need to move along. And if we hit a silence, I'll be ready to call on you if necessary. So with that, let's get started with some of our steering committee members first. And don't forget to unmute when it's your turn and mute again when you're done. Go ahead, please.
My name is Sheila Moyer, and I'm here on behalf of the BC Federation of Labor, and we represent over 500,000 members of our affiliated unions.
My name is Scott DeLong. I'm here on behalf of the BC General Employees Union, and we represent about 85,000 members.
Hi, I'm Shannon Dubb. I'm with the Canadian Centre for Policy Alternatives. We are a public policy research institute.
My name is Tuesday Andrich. I am here on behalf of CUPE British Columbia, and we represent over 104,000 members in BC.
My name is Adrian Young, and I am here on behalf of Community Action Initiative.
My name is Leslie Gaudette. I'm here on behalf of the Council of Senior Citizens Organizations of British Columbia. We represent 70,000 members in our 70 affiliated organizations.
My name is Kane Say, and I'm here on behalf of the Health Sciences Association of BC. We represent over 22,000 members.
I'm Barb Netterpell, representing 50,000 healthcare workers in the Hospital Employees Union, and I also serve on the steering committee.
I am Christy Spruce-Raypill, and I'm here on behalf of the United Movement of United Professionals, and we represent just over 12,000 members.
Hi, I'm Eleanor Smith, and joining me is Linda Wilson, and we are here on behalf of United Food and Commercial Workers, 1518, and we represent about 26,000 members.
I'm Penny McCourt, and I'm representing Action for Reform of Residential Care. We represent 800 individual members and 50 organizations.
Sam Weiss from the BC Federation of Retired Union Members, and we represent 4,000 members. Thank you.
Arnie Lambert, BC Retired Teachers Association, representing 17,500 members.
David Ravensbergen, I'm here on behalf of the Council of Canadians, and we represent 160,000 supporters.
Hello, my name is Nola Galloway, and I'm here on behalf of Family Councils of BC. Thank you.
My name is Edna Sandoval, and I'm here in behalf of Fraser Association of Family Councils.
My name is Heather Stuckey, and I'm representing the Interior Association of Family Councils.
My name is Tony Dumoulin, and I'm here on behalf of the Jewish Seniors Alliance of Greater Vancouver, and we represent 555 members.
My name is John Richmond, and I'm here on behalf of the Sunshine Coast Alliance for Seniors Care Cooperative. And we represent the 6 members of our board of directors. Thank you.
Hi, my name is Nienke Klaver. Next to me is my husband, Ed Staples, and we are here on behalf of the Support Our Healthcare Society in Princeton. Thank you.
My name is Agnes Jackman, representing Vancouver and District Labour Council. We represent 60,000 workers across 80 affiliated unions.
My name is Lisa Dawson. I'm here on behalf of Vancouver Coastal Association of Family Councils.
My name is Marcy Johnsrud. I'm here today on behalf of Vancouver Island Association of Family Councils.
Thank you so much, everyone. I hope you're feeling as powerful as I am. I'd also like to give a special welcome to over 150 organizational guests who are here, who are not yet part of the coalition at this time. I'll just make a quick note. We will be disabling the chat for the next portion of the meeting in order to minimize distraction during the storytelling and questions. Back to you, Margot.
Okay, thank you very much. So we're now going to be looking at accountability for private for-profit long-term care operators. And Minister Dix, I will start with reading your mandate that states support delivery of better care to seniors by private operators, in particular of long-term care homes, by making them more accountable for the public funding they receive. And so if you could take 3 minutes to specifically address that mandate, and I will try, just need to let you know that if more than 3 minutes, I will have to respectfully let you know. We'll give you a 1-minute warning. So if you could report on achievements in long-term care in that particular area.
unmute. Thank you. Yeah, happy to report on some of the achievements. As you'll be aware, in BC prior to 2017, something we advocated for together, the vast majority of care homes, 85% of them didn't even meet minimum standards for staffing. 44 out of 295 facilities, because we directly invested in more staff in advance of the pandemic. 295 of 295 meet that standard, are funded to the 3.36, a significant and dramatic change. In addition to that, as you know, what does this mean for individual seniors? It means 2 hours and 20 more minutes of direct care every week funded by the provincial government. And that makes a difference in the lives of everybody. We are preparing and and consulting with the sector, including with you and with unions, on a new long-term care contracting model to improve accountability in this regard. But I'd add to that you see the difference in workers and in care. It's difficult to see it because we've been living through this period of pandemic, which as a family member myself, has been profoundly difficult. The number of people in the community sector in the bargaining association has increased by 36%. In the facilities bargaining sector, which is recognized, is by 27%. And in addition to that, in terms of contracting, we essentially raised the wages of everyone in the private, for-profit and not-for-profit contracting sector through wage leveling, $165 million directly to workers. These are significant changes that both give workers more money and authority and rights, but also raise the standard of care both in public and in private contracted facilities that are paid for through public funds, of course. This is the most significant change that's happened in any jurisdiction in this period, not just in Canada, but across the world. We are the jurisdiction that's gone in this direction. And that, along with increased accountability in future, I think makes a profound difference to seniors and to everyone else. Finally, I'd just say this: we got rid of Bills 29 and 94, as we committed to do through Bill 47. And this has increased the power and agency of workers. And we're taking steps to empower individuals living in long-term care by getting rid of the first available bed policy, which you had called for and so many of us had called for before, and giving seniors and their families a choice. And soon legislating increases in the power of family councils to ensure greater accountability for them. It is a record that is without equal across North America and across the world. Doesn't mean it can't be better. And I look forward to hearing to the people who will give testimony of some of the ways that it can be improved.
Thank you very much, Minister Dix, for that. And we will now be moving to hear some personal stories from some family members who have family member in long-term care and also some employees. We will start with Nola Galloway, a family member of a senior in long-term care. She'll tell us her story. And Nola, if you take 3 minutes to tell your story and then a minute to pose a question for Minister Dix. Thank you so much.
Thank you. Hello, everyone. My name is Nola Galloway. I previously had a family member residing in a long-term care facility here in BC for 7 years, and I continue to be an active member of the Independent Family Council. Our family council felt there was just not enough staff to care for the needs of our residents. There were numerous concerns about care being brought forward to family council by family and friends of the residents. Yet, management told us point blank that the facility operator was meeting its direct care hour accountability as prescribed by the health authority, and the health authority confirmed that. We obtained the definitions of direct care and indirect care from the health authority, which provided us yet another indication that something just didn't appear quite right. In our facility, the care aides are sent to perform food services tasks in the dining room over 3 meals each day. These appeared to be indirect care, non-nursing tasks. So we wondered if the care aides should even be doing such tasks. We wrote the Health Authority Board, and their response clarified that while a facility operator is allowed to deploy their direct care nursing staff to perform non-direct care tasks, these hours worked must not be reported as nursing hours on the direct care hour nursing report, which is submitted to the Health Authority quarterly. On paper, it appeared that the facility was meeting its direct care hour accountability, but it wasn't. Our facility operator was inaccurately reporting all the hours worked by our care aides as though they were being worked only in the capacity of direct care nursing. That report is submitted by the facility operators solely on the honor system. There is no oversight or audit done by the Health Authority. Our family council calculated that our residents lost out on approximately 30,000 hours over 4 years. This inaccurate reporting benefited the bottom line of the facility operator company. The facility operator saved approximately $500,000 in expenses over that 4-year period because of this inaccurate reporting. Had our independent family council not persisted, even when the facility operator and the health authority kept telling us that the direct care hour accountability was being met, this inaccurate reporting may still be going on to this very day at our facility. And if it happened at our facility, how many other facilities may this inaccurate reporting also be happening at? Minister Dix,
1 minute, Nola.
Minister Dix, inaccurate reporting leaves long-term care residents without the adequate support they need. While we appreciate that the government has steadily increased funding for direct care hours, if the facility operators are not stopped from inaccurately reporting direct care hours, those public funds won't result in more hours being delivered or more care being received. We need you to ensure that public funds intended for the direct care of residents is spent only on direct care for the residents. Minister Dix, my question to you is, will you standardize reporting for direct care hours so that staffing levels and ratios can be independently verified and enforced? Thank you.
Thank you, Minister Dix. If you want to take 3 minutes to respond to that question.
I don't think we'll need 3 minutes on this one.
Okay.
We are, and I think it's important because, Nola, I think it's important to ensure, one of the reasons it's important to ensure the independent role of family councils is exactly this, that it's important for families to feel that they have agency and they can have a positive response to make. It's why in the next week we'll be announcing regulatory changes to ensure a standardization of the role of family councils across British Columbia. It's an important aspect and a central one, and one that you've been working on a long time and I've been working on a long time. Secondly, we need to standardize across health authorities and types of care facilities our standardized contracts. So we're expecting the same things and people get funded for the same things. We routinely take money back if the direct care hours are not met. Health authorities have to impose that, and we have to continue to do that work. But I have to say that we have a real insight into these matters now because, as you know, especially in contracted care homes, we lifted the salary of virtually all of the employees to the Facility Bargaining Association level, $165 million investment. And since we, of course, are paying for that, we have insight into the fact that we have, the improvements that have been made in direct care hours since 2017, which have been significant. So increased direct care hours, funded the HCAP program, which along with the infection control program have added 6,600 workers across the sector, right? Lifted everybody's salaries, given more authority to family councils, and are working now on a new standardized model so we'll have a better accountability from long-term care homes across BC. I think that's a good record. There's more to do, as you've highlighted, and it's certainly my intention to do so.
Okay, thank you very much, Minister Dix. And now we're going to hear from Heather Stuckey, who's also a family member of a mother who has been in long-term care. Heather, you have 3 minutes for your story and 1 minute for your question.
Thank you. I'm the chair of the Interior Association of Family Council, and I'd like to share my personal experience of my mother's 6 years spent in a for-profit long-term care facility in BC. If you've ever experienced what it's like in a long-term care facility, you will understand that there was quite a learning curve for new residents and their families. After being on a waiting list, a room became available and Mum moved in. My mother and I had little emotional support, and we were very ill prepared for the entire process. I am grateful, but I can't help thinking that this process could have been so much easier on all of us with a little more finesse or coaching. We were alarmed at the level of aggression with a couple of the residents, and I asked if my mum would be safe in her new home. The answer was always, of course she will be, as I saw the staff racing around, or worse, not finding any staff. In very short order, staff recommended an antipsychotic medication be prescribed by her doctor. After that drug completely snowed her, the doctor and I consulted, and she agreed Mom didn't need it. There was never a purple dot on her door. It deeply concerned me that the use of a strong medication was used as a restraint on a resident with very minor resistance to care. With a visible shortage of staff, it was difficult not to wonder who the drug benefited. I had never been informed of family council until I received a notice of it dissolving in the mail. A small group of us came together to commit to reinstating the family council after learning our loved ones hadn't had a bath for over 3 weeks. After plunging into this endeavor, because quite frankly, I was angry, it has become very rewarding as it gives families insight into challenges the facility faces, and it gives families an organized, united group to discuss concerns and successes we feel are important. I feel compelled to say there has always been a genuine willingness from all of the general managers that I have encountered toward family council. I also feel it necessary to point out that although my mother endured some very disturbing incidences in her long-term care journey, there was also some very kind and beautiful times with some staff members. During my mother's 6 years at this for-profit facility, we have gone through 5 general managers and 4 directors of care. We have been without a director of care for over a year. We have been without RNs, and rarely were any of the management team around on weekends. The use of agency nurses would fill in, but the resident gets no sense of familiarity with that individual. Person-centered care must be very difficult when you don't know an individual. The units were consistently short on all levels of staff, and care aides routinely were forced to do food service duties. After inspections by the health authority revealed several contraventions, an administrator was assigned for the second time. There was an immediate halt on admitting new residents. That was nearly 3 years ago, and still several contraventions are unresolved. We are now down to 26 residents from a possible 80, with an additional private wing closed as well. It is my understanding that the health authority continues to pay for these empty contracted beds. This hardly seems practical when we hear of hospitals filling up with dementia patients and others with long-term care needs, seeking to find a safe place to call home. Minister Dix, for-profit operators spent about $10,000 less each year per resident than nonprofit operators. They failed to deliver 207,000 hours of funded care, yet generated 12 times the profit than nonprofit operators, $34.4 million in profits. To ensure that seniors like my mother receive the care they deserve, we must remove the financial incentive for operators to do anything other than provide as many hours of care as possible with the public money they receive to deliver direct care. So my question to you, Minister Dix, is, will you require that all contracted long-term care facilities that receive public money clearly and publicly report revenues and expenditures, and ensure that all surplus funds be spent on the care of seniors or be returned? Thank you.
Minister Dix, if you can take 3 minutes to respond to that question.
Heather, you're in Summerland, right? Yeah, okay. I know the care home, and we, well, and as you'll know, a couple points for starters. One, your experience with family councils is not everybody's experience, and I think Nola will say this, I'm sure you'll say this, and that's why we have to take steps, as I've noted before, I won't dwell on this point, to increase the regulatory authority, the legal authority of family councils, both to exist and to get the information they need to serve as family councils and to advocate for residents. Secondly, as you know, we've taken steps to take over a number of healthcare facilities in BC since I've been Minister of Health, principally from one company. And that company, I don't think it's any secret, is Retirement Concepts, which is, I think, the company in place in Summerland, but also on the North Island, also in Nanaimo, also in Victoria. And those steps were taken because of the regulation that we brought in place and the determination of maintaining care standards. Thirdly, if they don't have people filling the beds, they don't get paid for those beds, just to be clear. Heather and Noel and everyone, that's not, however, sufficient, right? We expect those beds to be filled. We need people to have access to those beds because they provide better care, and we want them. We know that there are people in the Interior Health Region, for example, waiting in what are sometimes called ALC beds in hospitals. So it's not enough to say we don't pay for beds we're not using. We want all of those contracted beds to be available to seniors in Penticton and in Summerland who need access to those beds. So you're exactly
Sorry, Minister
right.
Dix, can I just interrupt? Can you address the issue of needing to report revenues and expenditures so that all surplus funds be spent on the care of seniors or be returned? So if you could just,
I think in the first question, and I was
just want to make sure we have
specific to the points that Heather was making in her presentation, and continue to do that. That we're, as we're committed to providing a province-wide standardized funding formula will increase transparency and accountability. I think it's fair to say that funding formula and that change might have been in place, but we, of course, have been dealing with the COVID-19 public health emergency that has profoundly changed long-term care in some of the ways that I've described. So that's the process we're going through, and that was the answer I gave to the first question and addressed that question as well in that. So I'm happy to do that, but I think it illustrates, I think, the important point that we have to view as both the regulators and the owners of part of the system, which is to ensure a consistent level of care. Well, residents and their families do have some choice in long-term care homes as a practical matter, especially in smaller communities outside of Metro Vancouver, South Island, and other places. That choice is limited by the number of care homes in the area. It certainly is in Summerland. And it means that the standard has to be high. And that's why you've seen us take a more active regulatory role in places such as Summerland, but not just Summerland. Why we have to ensure that the public money that's spent maintains high standards, and why we need all of the beds that we contract to be available to seniors in the region. And it's not just enough to say we're not paying for the beds, we want to use them all.
Thank you so much for that. Now we will hear directly from Erna Mendoza, a care aide in private long-term care facility. And Erna, you have 3 minutes to tell us your story and 1 minute to pose a question for Minister Dix. Thank you, Erna, over to you.
My name is Erna. I have been a care aide for 12 years working in a for-profit facility that subcontracts care work. The pandemic has been hard. Policies like wage leveling has been so useful. My hourly wage went up by nearly $5. But we are still working short-staffed. Short staffing has been a major concern for most of my career. After I finished school and started working as a care aide, I was laid off because of contracting out. When I came back to work, 90% of my coworkers had already left. The employer broke our contracts and I was rehired at $2 less an hour. Short staffing has been bad for a long time and was especially bad during the pandemic and is still a challenge. We work short nearly every week. We have 2 big floors with 38 residents. There are supposed to be 5 staff on. When we are short staffed, there are only 3 staff in that unit. Then staff are equalized and move staff around. Then all units become short staffed. When working short staff, we have to prioritize. Some residents who need a bath
can't have one because the bath girl has to step up to do care. Sometimes the residents' meals are late or missed. If you have 38 residents and only 3 staff working, it's very hard to get everyone meals on time. When working short, we try to prioritize residents with complex care needs. Some of them are anxious or have mobility issues, and they are susceptible to fall. If possible, we want to avoid all falls and complex consequences. Everyone suffers when we are short-staffed. Staff suffer, and we are constantly rushing because there is always a resident waiting for you. Because staff are rushing and the workload is heavy, we get a lot of muscular injuries. It is normal for one care aide to be responsible for 7 to 8 residents. But since we are usually short-staffed, the ratio almost doubles, and we care for up to 12 residents for one care aide. At the end of the day, staff are burnt out. Sometimes you work 16-hour shifts and can't even take a break. Staff regularly call in sick or just don't come to work. We have a major problem with retention. Staff feels that the hard work that we do, wages and lower benefits, is not sustainable. Not worth it. One reason we are short-staffed. With a private facility, we don't know how much money the government gives to this facility. But if it's the same as the money transferred to the public facility, it's hard to see where the money is going. There is no accountability and no transparency because the private facility is for profit. It feels like they are focused on making a profit instead of spending more money on staffing. We know that the conditions of work directly impact conditions of care. Short staffing is hard for everyone. Minister Dix, I end my story by asking you this question. Will you ensure that all facilities that receive public money are required to be a part of a public sector master collective agreement and to ban exploitative subcontracting practices?
Thank you very much, Erna. Minister Dix, if you'd like to take 3 minutes to answer that question.
Well, first, and this is important, we've given more power to the BCGU, to of course the HEU, to other unions in the sector by getting rid of Bill 29 and 94, which led to the worst excesses and have empowered workers to defend their rights in the workplace, not just government action, but the strength of those unions. It was a significant difference. Secondly, as Erna said, and thank you for all of the work you do, Erna, the wage leveling raised salaries across the sector. I want to understand what this means, because the question was about bargaining association salaries and collective bargaining. What Erna's talking about is a $5 an hour wage lift in her area, 165 million across the sector. This was the amount under the Facility Bargaining Association agreement that private and other contractors were paying. That was money effectively that was taken away or contributed by workers every year to the sustainability of the long-term care system. We've made that change. We want to continue to pursue it to ensure that that Facility Bargaining Association floor is there for all workers. I think that's important. Thirdly, we've repatriated workers because many of Erna's colleagues especially in public long-term care homes who were doing important work in the care home had their work contracted out. And we have repatriated that work in care homes and in hospitals across BC for thousands of workers. That process is going on and continuing to go on. And finally, as we said, we need a contracting arrangement that increases accountability and transparency so that Erna and everyone else can see what a care home is doing and ensuring that we meet our obligation to high standards for residents. This is a significant action. And I just want to say, well, you know, governments often say, well, this is what we did. It's what we did, all of us together, all of the groups on the line advocated for every single one of those changes, and they made difference in the lives of workers and others. Final thing about short staffing, which is an important question, in addition to the collective agreement questions, the short staffing question means that we have to continue to hire more people. When you raise care standards, you have more demands across the system, you need more people. The age cap program that we've put in, the hiring of thousands of workers that have come through that program, we need to continue it, not just in long-term care, but in home care and home support, in order to increase the number of workers that we will need as the number of seniors increases over the next decade. We need more care home beds, we need more workers, and we need to continue to campaign to ensure that we're not just short-staffed, but that we meet the future demand, which is going up.
Thank you very much, Minister. I just wondered if you could speak to the public sector master collective agreement. Is that something that you see compelling all facilities to be a part of the master agreement again? You could just take a minute to address that.
We haven't done, but we have, of course, ensured that all workers had their wage leveled up to that facility bargaining association agreement. I don't want to say too much about public sector collective agreements right now because one of them in the facilities is being voted on as we speak. And so I don't want to say too much about that. Others are being negotiated, but I would say this, that because of the people we've brought back into those bargaining associations in the community, 36% more workers. In a labor shortage, 36% more workers than that, and the facilities, 26% more workers. That's workers and healthcare professionals, healthcare workers and healthcare professionals. That shows what we've been doing in practice, not just in theory.
Thank you so much. At this point, we will just review the long-term recommendations that we've put forward. If you could bring that slide up, I'll just quickly review them. Long-term care policy recommendations, standardized reporting for direct care hours so that staffing levels and ratios can be independently verified and enforced. Require that all contracted long-term care facilities that receive public money clearly report revenues and expenditures to the public, and require that all surplus funds be spent on the care of seniors or be returned, and stop spending public funds on new for-profit long-term care homes by either building them in the public system or releasing a call for offers that is exclusive to not-for-profit long-term care. Thank you. At this point, we're going to move on to looking at expanding publicly funded home support. And your mandate, Minister Dix, says, improve and expand publicly funded home care to provide better care and help with daily living so that people can stay in their homes for as long as is safely possible, receiving care from a more stable group of care aides. And Minister Dix, if you could take 3 minutes to respond to that mandate.
Or 53, right?
Yeah.
Look,
thank you, you're being great. I'm not having to interrupt you.
Look, I think on home care, and on community-based support services, which are effectively home care and home support and the delivery of home health care services. It's been a very significant priority. I want to emphasize, because this is something that had been advocated by the health coalitions and many of the groups that are represented today, that we brought into the public sector in Fraser Health and Vancouver Coastal Health and VHA, many private contracts that have been private for a very, very long time. We did that, of course, back in 2018, and we did that because it made sense, because it delivered better care and allowed us to try and respond to the challenges facing the system in a better way, in a public way, and in a unified way. I must say that not having 12 contracts to manage in home support at the time of the pandemic was certainly demonstrated the value of doing that. I also want to acknowledge that this has been an extraordinarily difficult time. We've had family members, I've had family members both in long-term care, so the experience you felt, we felt, and receiving home support at different times, and this has been a phenomenally difficult period. In that period, we've increased the community-based services, in other words, nurses and other healthcare professionals visiting homes, by about 23%. Prior to the pandemic, we had dramatically increased adult day programs in an unprecedented way, and respite services. That was profoundly affected, as all of you know, by the pandemic, when many of those programs, virtually all of those programs, had to be shut down. And on home care, we significantly increased the number of hours. But we know, and you know, that the demand still consistently, it may have increased more than population share, but the demand consistently goes beyond the number of hours and the number of supports provided. And that in the future, both home support and community-based home services and adult day programs and respite care will need to be increased. We're going to see in British Columbia twice as many people over 75 in 10 years. This isn't bad news. This is good news. As someone who's 58, it's good news that people, that our life expectancy in BC.
Okay, thank you. If you could just finish up on that comment, 30 seconds.
But just to say that, you know, we will not be able to build out a long-term care system at that size. We have to improve home care and home support services, and the issues that you're raising here today will become more profound, not less profound, in the coming years. Okay. And it's why we have to focus on hiring more home support workers across the system.
Thank you so much. And now we're going to hear from Margaret Coots, who will be reading on behalf of another senior needing access to home support. Margaret, welcome. If you could take 3 minutes to tell us your story and 1 minute to pose a question for Minister Dix. Welcome, Margaret.
Thank you. Yes, my name is Margaret Coots, and today I'll be sharing a story from my neighbor who is a low-income senior.
I think so.
I'm sharing it with her permission, as it speaks to the lack of home support access in this province. I'll do it in the first person. I live alone in a one-bedroom apartment. I deal with several chronic health conditions and reduced mobility because of that. I have what one doctor described as a constellation of medical conditions. In addition, I have a tight budget. I want to keep living at home and to age in place, but I need support to do it. A few years ago, I had a serious health event that required hospitalization, and in March 2016, I was finally able to return home. At that time, a Vancouver Coastal Health occupational therapist did an assessment of my ongoing needs. In addition to a sturdy walker and grab bar through the bathroom, she recommended that I have housekeeping support for tasks such as washing floors and doing laundry. A service agency followed up to confirm which services were needed. The representative had me fill out the application for a subsidy, and I was subsequently approved for it. It was going to cost me $20 for a 2-hour visit twice a month. However, there was no further contact from the service agency until 2019, more than 2 years later. I received a call from them telling me that I could move up the waiting list if I paid the agency $75 a month. I was appalled, not just because I personally couldn't afford to pay for the privilege of moving up the line, but because this meant others must be receiving the same kind of call. I spoke to my doctor, who referred me to a social worker. They both agreed that the request for money was inappropriate, but he said it was an issue for Vancouver Coastal Health. I called BCH, who advised me to call the service agency to complain. However, the representative at the service agency declined to look into the matter. Again, I was appalled. It seemed to me that Vancouver Coastal Health should be very concerned about an agency that is doing that. At that point, I gave up. I continued to need housekeeping support that was identified in 2016. Without them, I have to rely on the support of friends and neighbors. She has no family here. Minister Dix, like my friend, most seniors would prefer to live at home for as long as possible. Yet over the past 2 decades across, access to publicly funded home support in BC fell by 30% across all health authorities. Gaps in service exist because the current provincial home support program does not include services for the provision of instrumental activities of daily living, has a narrow definition of activities of daily living, and is one of the only provinces that charges a fee, the current regulated daily rate co-payment. With limited comprehensive and affordable services available, seniors, particularly low-income seniors, do not have access to the support they need to age in place.
30 seconds, Margaret, if you could finish up, please.
Well, I guess the question is, we request that you remove the current regulated daily co-payment and address the other barriers that fragment in services and long wait lists.
So Minister Dix, yes, will you make home support more accessible by removing the current regulated daily rate co-payment? We heard from Isabel McKenzie earlier about BC having one of the highest rates and the exorbitant costs for seniors who often cannot afford it and go without, or sometimes move into long-term care early before they need to. So it's a real issue in BC. We just wondered where your government is with regulating the daily rate co-payment or removing the current regulated daily co-payment.
So thank you, and thank you very much, because I think a number of issues were raised by Margaret. The co-payment is one, but also the hours available and the kind of care available. I think, have I got that? And those are some of the choices facing us. And of course, increasing the number of people who can access publicly funded home support. On the latter, as Margaret and the coalition have said, we saw a real diminution in over a long period of decades in the amount of home care and home support. Everyone talks about how they support home support, but people don't do sufficiently enough about it. And I described the increases that have been made in the home support hours, even in the pandemic, so that we've seen a significant increase in both home support hours and community-based support services, which are essentially our nursing services, essentially across community, which are very significant increases. So we have to do that, but we do have some choices that we have to look at as well as we continue to expand out and see those budgets increase significantly and the support increase significantly. We've largely brought home support and home care in-house. That's good news. We've increased the number of hours dramatically. That's good news. And the question now is, do we address the issue of co-payment? Do we increase the number of hours? What aspects do we put in place now to ensure that people have better access to care? The vast majority of people who get home support, home care and home support in BC do not pay the co-payment or pay a minimal co-payment, but it affects a certain group of people. But as well, I would argue, on the margins of receiving home care and home support, a lot of people's income is fairly low and unequally felt. So we are looking at all ways to improve home care and home support, not just one. The question is, and we certainly are interested in your advice on this in terms of the investment of hours, the increase in hours for individual residents so that they can do more and stay at home longer. And then the issue of cost. I just note finally that, yes, I've heard this issue of moving into long-term care that Isabel have raised and met with her about that issue. I do think, and all of you know, that you pay in long-term care 80% of income. So it's not that people do not contribute in long-term care as they do in other places. I'm not sure that it's a big issue in long-term care, but it is a big issue for many people who receive home support. So these are the issues we're looking at. Do we increase the hours per patient? What steps do we take to expand the breadth of home support so that more people can live at home longer? And thirdly, the issue of the co-payment. These are issues, of course, we're all looking at.
Yeah, thank you very much. So now we're going to move on to hear from Florentina Kelly, a community health worker. We'll talk about working conditions for home support workers and the impact on care provided. Florentina, you have 3 minutes to tell us your story and 1 minute to pose a question for Minister Dix. Welcome, Florentina.
Thanks, Margaret. My name is Florentina Kelly. I have worked as a community health worker for 21 years, and I love my job. For those who don't know, community health workers are frontline workers that work in seniors or clients' home. The work that we do is mostly nursing tasks, which we provide personal care, give medication, change catheter bags, putting eye drops, just to mention a few tasks. We have clients booked for 30 minutes, which only 20 minutes is actual service. 10 minutes is for travel time to get to the next clients. This includes driving around looking for parking or risk of getting parking tickets, waiting for the client to open the door or answer the buzzers, going through the elevator and asking the client screening question because of COVID, or also reading the client care plan. We love our job, but we cannot give quality care to our clients in that time frame. Many community health workers have a regular positions, but are treated like casual because work hours are not guaranteed. There is a window of availability, like to get at 8 hours work, they have to have 10 hours window. I have for example, if the worker goes to work, if you don't have a client from 9 o'clock until 11 o'clock in the morning, they will be sitting in their car for 2 hours and not getting paid. For all this reason, many community health workers are moving to work in long-term care facilities because they don't have to drive all over the place and the pay is better. Their hours of work are guaranteed and they don't have to pay for car expenses like community health workers. Low wages and lack of guaranteed hours are the reason why we have issues in recruitment and retention for community health workers. Minister Dix, right now it would be impossible to expand home support because there are not enough community health workers to meet the demand. According to the senior advocate report, not only are home support workers paid less than care aides in long-term care, even though we have equivalent training and do the same work, plus nursing tasks. Home support has the highest rate of casual workers and the lowest percentage of full-time position compared to any healthcare occupations. Without guaranteeing hours or valuing our work, many of us will leave to seek more stable employment. Also, community health workers have no paid coffee breaks, that 10 hours per month non-paid hour.
Florentina, you have a minute to finish up.
Okay, my question is, Minister Dix, will you address the staffing crisis by increasing the wages of community health workers so we are paid the same no matter where we work, and create stable working conditions by guaranteeing paid hours? I have another question later. Thank you.
And Florentina, thank you so much for that. Minister Dix, if you would like to take 3 minutes to respond to Florentina's question, thank you.
Thanks, Florentina. And it sounds like we're going to see you at the bargaining table, and I like that. And I don't say that just glibly, though. As you know, in the community sector in particular, that bargaining association has increased by 36%. What that tells you is that we've dramatically invested in that sector and we've repatriated a lot of contracts, and you see that reflected. And so the work that's done in the community, and it's obviously not just home support workers who are in that sector, but it's a lot of them, community health workers and healthcare assistants who work in that area, who play an important role. I'd say a couple of things. We've increased the spending in this area on home support, publicly funded home support, from $488 million to $693 million since I've been Minister of Health, which is, I have to say, a staggering increase. Only ambulance paramedics and mental health addictions have received that level of increase over time, reflecting the priority we give. Secondly, what Florentina says is absolutely correct. We have to ensure that we give equal priority, and this sometimes during the pandemic we didn't do because of the focus on long-term care, equal priority to getting staff in this sector as other places. And that's why we opened up the HCAP program to home support, and I think we've added about 320 already workers to the to the community from that program, and we're going to have to do significantly more and expand out that program significantly more. With Florentina having, as a opposition member and as Minister of Health, gone around with home support workers, not inside, but around as they do the routes they do, I understand the extraordinary work that they do and the real specific challenges to that work that makes it a hard competition with other sectors. So the wage and benefits issues are largely dealt with at the bargaining table. But there is no question what Florentina says, that we have to address and expand this sector. And that's what we've been trying to do, an unprecedented increase in spending, in hours, and in supports. And still, Florentina will tell you, and all the people who work with you will tell you, it's not sufficient. So we have to continue to build that case and do more.
Thank you, Minister Dix. And I think that will wrap up what we wanted to present this evening. Thank you so much, Minister Dix and Mabel Elmore and everyone. There will be a more extensive thank you to everybody, but I want to personally thank everyone, especially Minister Dix, for your time this evening. Thank you so much. And I will pass it over to BC Health Coalition people to do a formal close.
Thank you so much, everyone, and thank you, Minister. Thank you, PS Elmore. I know that we do have a slide to just review those home support recommendations as well. So I think we wanted to make sure Minister could make his the next commitment, but we'll put that up. We'll have you read it, and then we'll say goodbye to everyone.
Okay. Thank you so much. Home support recommendations. Make home support more accessible by removing the current regulated daily rate copayment. Address the staffing crisis by increasing the wages of community health workers so they are paid the same no matter where they work, and by guaranteeing hours to create stable working conditions. Thanks, Minister.
Hey, thank you, Margot. And I'm here for the recommendations. So well, and I'm here to the end. So thank you. I just want to thank everybody who participated in all the excellent presentations. Thank you very much.
This is also a great time for us to re-up that link in the chat for everyone. Comments and questions, we will send them to the Minister's office, and we will hopefully keep all of this going again. So thank you again to everyone.